Welcome to ASPA's December webinar. My name is Hope, and I will be your conference facilitator today. Before we get started, I would like to briefly go over the format for this presentation. There will be two parts, a 45-minute presentation segment and a 15-minute Q&A session. In order to stay within the allotted time frame, all phone lines except those of the presenters will be placed on mute during the presentation. This will not prevent you from asking questions during the presentation. You may post written questions using the chat box located to the left side of the slide. After the presentation has been completed, all questions will be addressed during the subsequent Q&A session. I would now like to introduce our speaker, Dr. Tina Ipe. Dr. Ipe is the Medical Director of Donor Services and the Associate Medical Director of Transfusion Medicine. She is a clinical pathologist in the Department of Pathology and Genomic Medicine at the Houston Methodist Hospital. She is an assistant professor at Weill Cornell Medical School. She completed her medical school training at the Medical College of Virginia. Her residency is in clinical pathology and a fellowship in blood banking transfusion medicine at the Hospital of the University of Pennsylvania. Dr. Ipe, you may begin your presentation.
Thank you so much for the kind introduction. I hope that everyone can hear me. I'm pleased to be speaking with you on vascular access in apheresis. You know, while I was interviewing for my job at the Methodist, I remember being astonished at the number of apheresis procedures that were being done peripherally at Houston Methodist Hospital. So much so that I went back to the institution that I was training at and asked for the next leukapheresis to be done using peripheral venous access. I'm sure this was much to the chagrin of my apheresis nurse and attending. And we were able to do the leukapheresis successfully, and it was performed much faster given that we did not have to wait for line placement. Many of you know that line placement, especially a central venous catheter, can be a long ordeal. So I would like to mention that this is a Terumo-sponsored presentation. However, I can assure you that these slides are my own, and they represent my thoughts based on my current experience. So vascular access is important for performing apheresis procedures. And without vascular access, the procedure of removing blood, separating the component of choice, and then returning the rest of the components back to the patient, it simply cannot be done. So given its importance in the performance of the procedure, I am going to highlight the different types of vascular access used in apheresis, review the benefits and risks associated with each of them, and focus on peripheral access by highlighting the experience of Houston Methodist Hospital in having a successful and busy apheresis clinic that really performs its procedures through peripheral vascular cannulation. And I hope you guys just get used to me. I'm really learning how to do some of these toggling. So just bear with me for a few minutes. I just wanted to see how this works. Okay, perfect. So access problems, as you can see, are really are notable concerns to an apheresis service. As illustrated by the tables seen both here, in the recent update of the World Apheresis Association registry data, what one sees is that access problems actually can be an adverse event. The WAA registry was first created in 2003, and data from different participating centers around the world have been collected and published. This study was published recently in 2016 and included prospectively collected data on some technical aspects of apheresis. In this study, a total of 50,846 procedures were reviewed in roughly 7,142 patients. And what you see on the left is that access problem is a mild adverse event that resulted in 130 adverse events per 10,000 procedures, and a severe adverse event that resulted in 2 adverse events per 10,000 procedures. Mild adverse events were classified by these authors as those that the patient tolerated without medication, and severe adverse events were those that prevented the continuation of the procedure. In this registry, mild adverse access issues could have been easily corrected, potentially by the reinsertion of the needle, for example. And of note, other vascular issues were separated out for the mild adverse events, which were hematoma and phlebitis. And as you can see, hematoma at the puncture site was resulted in 10 adverse events per 10,000 procedures, and phlebitis, which resulted in 2 adverse events per 10,000 procedures. For severe adverse events, you can see that they separated out flush, which I'm assuming is flushing of the vascular access, which actually resulted in 2 adverse events per 10,000 procedures. So because lack of vascular access can complicate therapeutic apheresis procedures, I will briefly highlight the different types of vascular access used around the world, and in particular at our institution. So the access types are temporary central venous catheters, or otherwise known as non-tunneled catheters, permanent or tunneled central venous catheters, arteriovenous fistulas and grafts, totally implantable venous access systems, also known as ports, peripherally inserted central catheters known as PICCs, arterial access, and while it has been mentioned last, and it is very important, is peripheral venous access. Central venous catheters are one of the several options available in obtaining vascular access in the patient. And what one sees in this figure is a short-term or tunneled catheter, a short-term or non-tunneled catheter is one in which whose entry is actually in the internal jugular vein, usually, and whose tip actually terminates usually in the superior vena cava or the right atrium. The catheter shown here actually has a double lumen and is usually better for the performance of apheresis procedures, the double lumen. Central venous catheters possess characteristics that often make them desirable for apheresis, such as increased blood flow, reduced resistance, and decreased potential for recirculation. And non-tunneled catheters, which is shown by this picture, is really used for short-term therapy and in emergent situations. In comparison, long-term or tunneled catheters really can be used for months to years. And what one sees in this figure is a tunneled or long-term catheter that actually has a single lumen. We tend to perform most of our procedures actually using the double lumen. But here what one sees is that the entry site is usually in the subclavian vein, and again with the catheter tip resting at the superior vena cava or the right atrium. So the two types of fistulas that are presented in the slide is the radiocephalic fistula that is seen on the left, and the brachiocephalic fistula, which is seen on the right. Arteriovenous fistula involves a direct anastomosis, of an artery and a vein, usually at the wrist, as shown with the anastomosis of the radial and cephalic radial artery and the cephalic vein on the left image. There are several advantages in that it can be used for long-term use and has a good flow if it functions adequately and has matured well. In comparison to a CVC, it is more cosmetically appealing to a patient and has lower risk for infection. An arteriovenous graft, for which I was really unable to find a good illustration, was really constructed similarly, but it interposes a prosthetic graft between an artery and a vein. So ports are similar to a central venous catheter in that they're also tunneled under the skin. The port can then really be accessed using a non-coring access needle, and it can be used long-term in patients undergoing apheresis. When not accessed, they only need an occasional flush, but otherwise do not require care. It also has a lower risk of infection. So I just want to, I'm going to take a moment here because I see that, that some people are having difficulty hearing me. Is that true? Maybe not. Okay. Perfect. I see that that I guess on Chrome, if you're not on Chrome, it might be better to open it on Chrome so that you are able to hear the presentation. So the next slide actually shows a peripherally inserted central catheter, and a PICC line is inserted in a large peripheral vein, such as the cephalic or basilic. And as what occurs is that the line is really advanced until it actually ends up in the distal superior vena cava or the cavo-atrial junction. However, the problem with this one is that when I reviewed the literature, I really had not seen the use of these catheters, and some of the papers were advising against the use of them for the provision of apheresis. So I would love to hear during our Q&A if individuals have used it and if they have used it successfully. So now that we have really covered all the types of accesses and their advantages, with the exception of peripheral venous access, I wanted to take the time to show the trends of these accesses around the world. So in a paper that was published by Stagmeyer and Wickdahl in 2003, patients undergoing apheresis really were accessed differently depending on the geographic location of their procedure. So for example, when you're reading the table going from the left to the right, if you are a patient in Asia, most of the procedures are really done through peripheral, through the peripheral vein or through an arterial puncture. However, in Europe, it is done primarily, again, through the peripheral vein. But what one sees is that in Central, South, and North America, apheresis is done primarily through central venous catheters, as seen here. Like overall, there appears to be a equal usage of central venous catheters and peripheral veins, However, if you look at the numbers that were included, it looks like the use of central venous catheters in the Americas might be skewed given that lower numbers of individuals were included from these places in comparison to Asia and Europe. So as seen in the previous table, institutions from Europe principally use the peripheral access for apheresis, and the French really are no different. A French plasma exchange registry collected data on the technical aspects of apheresis for 13 years starting in 1985. And the registry included a total of 14,183 patients that underwent a total of approximately 127,000 procedures. And what one sees that in this pie chart is that 71% of the procedures were performed using peripheral veins, 20% were done using central venous catheters, and the remainder, which was 9 and 0.2%, were actually done using either the arteriovenous fistula or graft. Many patients that were treated, like the conditions that were treated included neurologic, hematologic, and renal conditions. Here are the neurologic, and here are the hematologic and renal conditions and indications. But the most commonly treated were the neurologic and hematologic diseases. Similarly, the World Apheresis Association registries showed similar trends. As mentioned previously, in 2003, the WAA registry was created, and centers from all countries were invited to participate in this registry. The first report was actually published in 2007 by Stegmeyer and al. And in this data, and actually showed data from 3 centers in 2 European countries, a total of 122 patients and 388 procedures were included. What this pie chart shows again is that 63% of the procedures were really done using peripheral veins, and the remainder, 36%, were used using central venous catheters. That included sites such as the femoral, subclavian, and jugular. The second pie chart showed a similar trend, but this time the registry included data from 15 centers from 7 countries. And again, one sees that most of the procedures were actually done using peripheral venous access. So the advantage of using cannulation of peripheral veins will soon become apparent when we start reviewing the complications associated with the various types of accesses, which is going to be the focus for the next set of slides. In the paper by Schoenmark and Bosch, they reviewed vascular access in ICU patients. And what they found is that ICU patients are more likely to be accessed using central venous catheters given their many comorbidities. And as many of you know, central venous catheter insertion has early and late complications as seen in this table. The table is actually first divided into frequent and rare complications associated with central venous catheters, and then is further subdivided into early complications as shown in the light pink, and late complications as shown in the darker pink. Delayed complications are those that became apparent after several days, and the rate really increases after prolonged indwelling time. So among these, you can see that the more troubling complications of central venous catheters, which are numerous, are really pneumothorax and systemic infections. And systemic infections, according to these authors, were really caused by coagulase-negative staphylococci. So the complications associated with central venous catheters is also dependent on the location of the central venous catheter placement. So what this table shows is that it was a table that was presented in a study that was conducted by Bombar, and it shows that the subclavian catheter, subclavian placement of a catheter is really associated with the most number of complications in comparison to the internal jugular and the femoral, although the femoral follows very closely. So the study was conducted over 5 years with a total of 332 catheter placements in 82 patients, and septicemia as well as septicemia and thrombosis were the leading complications for the subclavian catheter location, while abscess, bleeding, and pain was associated with those of the femoral line placement. So this table suggests that access via the internal jugular vein might be the safest for the placement of a central venous catheter. So I'd like to mention that there are many complications associated with arteriovenous fistulas and grafts, and these complications have been seen, or actually have predominantly been studied and seen in renal dialysis patients, and have included aspects such as the left ventricular hypertrophy, myocardial ischemic events, Steele syndrome, thrombosis, infection, bleeding, and lack of maturation. What they have noticed is that AV fistulas are more likely than AV grafts to have primary failure, meaning that it really it never reaches maturity such that it provides reliable access for hemodialysis. And the most common complications of AV fistulas and AV grafts include thrombosis, infection, access-related ischemia, otherwise known as the vascular Steele syndrome. It also includes things like aneurysmal dilation and local bleeding. What they did say, from various literature, although I was not really able to get data as I had shown previously, is that thrombosis and infection tended to occur more frequently with AV grafts compared to AV fistulas. And this might be potentially due to, a placement of an artificial, of a plastic-like material versus an AV fistula in which there is just an anastomosis of an artery and a vein. And Steele syndrome, for those of you who don't know, is a syndrome where there is ischemia of tissues primarily because of the lack of perfusion. So this table illustrates the various complications that are seen in ports or totally implantable ports. And there were 700 ports that were implanted in the study done by Barbatakis, and 126, so 18%, had some complications. And the complications are listed in this table in the order of their frequency from those occurred most frequently to those that occurred the least. And what one also sees is that the early complications, again, are those in light pink, and the late complications are those in dark pink. One can see that pneumothorax and hematoma, cardiac arrhythmia, and arterial punctures are leading complications of ports versus catheter-associated venous thrombosis, port pocket infection, and pinch-off syndrome were late complications of port placements. So this final slide on complications is again from the World Apheresis Association Registry, and it actually shows that a large number of procedures are really done through peripheral vein-to-vein access, roughly 64.3% in comparison to other forms of accesses, including the jugular, which was actually the second most commonly used form of access. So the other thing I'd like to note is that while peripheral access was used the most, one can actually see that it had the fewer number of moderate and severe adverse events associated with it when you compare it to those of the central venous catheters and other types of accesses. The other thing I'd like to note is that central venous catheter had a higher number of moderate and severe adverse events. And moderate adverse events, just to let you know, is that they were defined by the authors as need for medications due to an adverse event, and severe resulted in actual stopping of the procedure. So now that I have, spoken so much about the different types of accesses, I really wanted to highlight the experience of Houston Methodist Hospital. So peripheral venous access is the preferred form of access at Houston Methodist Hospital. It is a 1,200-bed hospital that has a very busy apheresis service, and we perform both outpatient and inpatient apheresis procedures for a wide range of diseases and indications. We perform approximately 3,200 procedures annually, and we have a total of 8 staff members, but we're always looking to hire a few more good folks. Our staff are primarily apheresis technologists who actually come from a phlebotomist background, but they also include nurses. The type of apheresis that we use is a centrifugation-based continuous procedure for our apheresis treatment. So this is data that has not been published but will be done shortly. We had actually performed a 10-year retrospective review that ranged from the year 2006 to May 2016. And of a total of 3,341 patients, 2,363 patients, or 70%, were accessed peripherally. And of 21,357 procedures, approximately 19,823 procedures, again, were performed peripherally. As you can see, that there was an equal number of males and females who were treated. And I point this out because it's usually believed that females are often more difficult to access. But here our patients are equally distributed between males and females, and our patients, the racial group was predominantly Caucasians. So this bar graph illustrates that we treated a wide range of patients, and they went from younger than 9 years of age to over those who were 94 years in age. And the bar graph actually shows the racial distribution of the population for a particular age group. Again, the green are those are individuals that are Caucasian. Orange is our African American patients. Blue is our Asians, and the one in purple are we have not been able to determine their race. So I'd like to mention that as I had mentioned earlier, sorry, I'm repeating myself. I'd like to mention that we do treat a wide range of diseases and indications using apheresis. However, our predominant patient population tends to be those undergoing apheresis for neurologic diseases. Despite our frequent use of peripheral veins for access, our staff is also skilled in accessing other access types as well, including AV fistulas, AV grafts, and arteries, which is really uncommon for us, unlike our Asian counterparts. When we do access arteries, we tend to enlist the help of our vascular surgeons and anesthesiologists in helping us to place the lines, just because of the pressurized flow of the arteries. We also do use central venous catheters primarily in our ICU patients and high flow ports in our sickle cell disease patients who are undergoing chronic red cell exchanges. We do not use PICC lines, and our access is usually placed in large veins in the antecubital fossa or slightly above it. And this is because we feel like the vein, as you all know, should be able to handle the handle the negative draw of the machine. And the draw needle we use is a fixed metal eyed 16 to 18 gauge needle, a fistula needle. And we have not found a significant difference in the flow rates when we have used this range of gauge needles. The back eye needle helps us in that it helps to decrease the turbulence around the needle tip, thus potentially preventing the occlusion of the blood flow. And the draw arm for us is kept straight given the needle, and it has to be maintained outstretched throughout the procedure. The access vein also has to have sufficient length just to handle the length of the needle, which is not that long. Otherwise, one could potentially risk a hematoma or a puncture. So the return needle that we end up using is an 18 gauge intracatheter needle. And for return, we tend to use the smaller veins that are closer to the wrist, as the return flow is actually better accommodated by these smaller veins. We do try to keep our return needles from areas that actually might occlude the return flow back to the patient, and the patient is able to use this arm more readily or easily because the needle is more flexible once it's been placed. We also, are creative. We have used, just the peripheral veins only in one arm, instead of using both when we see that our patient has better vascular anatomy in one arm. And in particular, like when we use fistulas in one arm, the return is usually placed higher than the access. And for grafts, we tend to feel for the thrill. The stronger thrill is usually where the access point is, while the weaker thrill is where we place the return. So understanding vascular anatomy and palpating the appropriate veins to use is an invaluable skill that our staff possess. In addition, because our staff sees approximately 20 to 25 patients a day, they do get a lot of practice in obtaining peripheral access. I would like to mention that our chief technologist, Javier, has over 35 years of peripheral cannulation and has really mentored the rest of our staff to be able to do so as well. We also have one physician in our group, Dr. Christopher Lebec, who is also, has also been leading the forefront of accessing our patients using peripheral cannulation. We tend to use the traditional locations such as the antecubital fossa for access and the veins of the lower arm for return. However, we always remain, we try to remain flexible and have used veins in the hands also for the return. And the one that we have tended to use most often is the dorsal vein. Our staff also collaborate and help each other when they are faced with a patient who potentially might be a difficult stick, And we also have one more trick up our sleeve that I will introduce later once we have, as we get closer to the end of the presentation. So at our apheresis clinic, both for inpatient and outpatient procedures, an assessment of veins is performed to determine whether the patient actually can be peripherally cannulated. So the evaluation form is filled especially for those patients who come to us as outpatients and those who undergo peripheral blood stem cell collection. And an example of this is actually shown in the next slide here. So here is our, this is the peripheral venous access evaluation form that is used by the Methodists. And we peripherally cannulate patients that tend to have fair, good, and excellent veins. And often our comments include aspects such as the potential number of apheresis procedures that the patient might be able to handle. And again, this really goes back to our staff. You know, our staff they're really remarkable in that they have a very good understanding and really help to lead us in being able to access our patients peripherally. So during the assessment of our patients, we also do certain things like inquire about their past medical history, including the use of IVIG use and steroid use. We find that patients who actually have been treated for years with IVIG tend to have these cord-like vessels that can be difficult to cannulate peripherally. In addition, steroid use we have found actually makes their veins thin and brittle. We tend to educate our patients on being adequately hydrated prior to the procedure. We also set the expectations that it might be difficult to obtain access on the first needle stick and that multiple attempts might be needed. You know, I know that, we know that a few of our patients do become anxious, especially those who are first-time patients. So for our first-time patients, we do spend a lot of time explaining apheresis procedures, and we tend to tell them tell them that we are going to be always present during the procedure and that they can alert us if there is any discomfort when they undergo apheresis. But there are some who become very anxious, and we do advise them to take the anxiety medications if they are prone to it. And the other thing is we do tell our patients not to fast and to eat well prior to the procedure. So again, as I mentioned, we do perform a thorough vascular assessment of our patients' arms, and our staff also understand the risk factors for poor venous access. So the next few slides are a pictorial depiction of what I have spoken about. All the individuals that are present in these pictures have consented for their pictures to be used as part of this presentation. And so we will start with the picture on the left with one, and you can see that the patient is having a blood pressure cuff placed on her left arm by Javier. This arm will be used for access. A tourniquet is then placed on her right arm, which will be used for her return. Then you see in picture number 3, Robin is palpating the patient's veins. And the palpation of the veins can actually be done with an alcohol swab, which we've actually found to be helpful. And we believe it might be helpful because potentially it constricts the area, thus allowing for better palpation of the vascular anatomy. I have heard of other centers using heat potentially, but we tend to use the alcohol swab. And then after selecting the appropriate vein, what she does is she performs the alcohol swab again for disinfection of the area. And picture number 4 shows her providing 1% lidocaine where the return line will be inserted. So picture number 5 shows Robin inserting the return needle. Picture number 6 shows the completed return needle placement. Picture number 7 shows Robin palpating the antecubital area for access. And again, she disinfects the area after selecting her vein in picture number 8. What you see in picture number 9 is that she's again providing 1% lidocaine in this to numb the site where the access needle is going to be placed. Number 10 shows the completion of the access needle placement. Number 11 shows the access line being connected to the machine. And picture number 12 shows that the patient still is a happy camper, ready to start her apheresis procedure, which we're all happy about. So as I mentioned, our staff is also aware of the risk for poor peripheral access, and they include dehydration, thin vessel, scarring, and sclerotic vessels. As mentioned, we do educate our patients to be well hydrated and not to fast prior to the procedure, but we also do realize that age-related changes and medication-related changes really can affect vasculature, especially in the elderly and those who potentially take steroids or IVIG. So now that we have shown you some of our tips and tricks, when all else fails, starting in 2013 or early 2014, we actually started using the ultrasound. And these graphs are from a published prospective review of our patients who, both inpatient and outpatient, who underwent apheresis at Houston Methodist Hospital from July 1st, 2015 to September 30th, 2015. And what you see is during this interval, we were able to peripherally cannulate our patient 44% of the time without the ultrasound, and then used the ultrasound 20% of the time to further peripherally cannulate our patient. So the use of the ultrasound guided, or the use of the ultrasound really prevented placement of central venous catheters in roughly 20% of our population. And we find it to be very helpful. So here is a picture of our staff, including the physician. And as I mentioned, Dr. Christopher Levesque is is actually the pioneer for helping us become so well established in using peripheral veins for our procedures. Again, Javier is our chief technologist who has helped mentor the rest of the staff and able to peripherally cannulate patients. I'm the person here on the right, and then we have Dr. Salazar behind me. So, it was truly a pleasure to speak with all of you today.